Hi, this is Paul Slackus, Good News Broadcast, speaking to Dr. Oliver Sartor. Hi, doctor. How are you?
I'm doing great, Paul. How are you today?
Okay, good. You're down with are you down there in New Orleans with Tulane Medical School?
Sure, Tulane Medical School, New Orleans, Louisiana. No oil in sight.
Okay, we're involved with cancer research. Is that right?
That's correct. That's what I do every day.
Okay, you've been doing that for a bit?
Oh, about 20 years.
Only. Okay, all right. We're going to talk about a common male problem, like prostate cancer today, and there's some new medicine out there that I think is going to be helpful for people with prostate cancer. But let's start at the basic here. What is prostate cancer? What is the prostate?
Well, the prostate's a little male organ, kind of located right deep in the pelvis, below the bladder. And as it turns out, it makes part of the male ejaculate, makes part of the fluid. It does that, and it gets cancer. And that's about all it does.
Okay. And it gets cancer. Do we have any idea why it gets cancer? And is this the same cancer that's in the liver or other parts of the body? Or is it a different kind of cancer?
Well, really very different. You know, overall, if we look at cancers, it's about 110 different diseases, and every organ has its own types and own predilections. In terms of why it develops, not really very clear. We have risk factors, and these are clear. We know that men, as they age, are more likely to develop prostate cancer. And we know that if you have a family history, particularly a brother or father with prostate cancer, you're at higher risk. And we know that certain ethnic groups, particularly African Americans, are at higher risk for prostate cancer. So we do have some risk factors. We don't really understand cause very well.
Okay. And how long has this been has prostate cancer been around for 200 years? Or
oh, goodness, it's been around just as long as the human race. It affects people all over the world, and just for as long as we've known about prostates, there's been cancer. So it is a little bit of a more modern phenomenon in the sense that we now have men who live older. If the life expectancy is 45, then prostate cancer is not much of an issue. But, of course, today, if men are living well into their 80s, then prostate cancer is a much larger problem today than it has been in the past.
Okay, so now in the past, first of all, let's talk detection. How does somebody know they have prostate cancer, say, before they go to some doctor? What are they feeling?
Well, typically and ideally, we want to detect prostate cancer when there are no symptoms. Now, the typical early symptoms are very nonspecific. Maybe some difficulty urinating, maybe waking up at night, maybe feeling a little more urgency in terms of going to the bathroom or difficulty emptying their bladder. Those are very nonspecific findings, however. And, as it turns out that the symptoms of prostate cancer in most men are simply not detectable. We do have screening tests, and there's been controversy here. We use the PSA and the prostate exam. That being said, today the vast majority of men, about 95%, are picked up when there are not symptoms present.
What's a prostate exam?
Well, it's not the most pleasant thought, but the physician will put in a glove and insert one finger in the rectum, and you feel the prostate just in front of the rectum, and by doing so, you're detecting abnormalities that cannot be detected any other way.
It can't be detected through X-rays or PET scans and CAT scan, anything?
No, it's interesting. So X-rays of the prostate are unfortunately worthless, and PET scans don't work. And as it turns out, imaging the prostate has been difficult. And currently, there's no accepted method of prostate imaging that can distinguish cancer from non-cancer reliably.
And this PSA test is a blood test?
PSA is a blood test, and just drawn from the arm, and that turns out to be a reasonable test, but it's generated considerable controversy because it turns out that PSAs can be elevated for reasons other than cancer. For instance, men with a big prostate, or men who have an infection in the prostate, or maybe men who have been bicycle riding or whatever, or are having sexual activity. All of those are potentially associated with an elevation in PSA. So the PSA is not a specific test, and it typically would lead to a biopsy, which is specific, and that happens about 1 million times each year that men will get a prostate biopsy in the United States.
Okay. So now, unfortunately, then somebody has it, and it's been detected, and now what are we doing? Is there stages in it? How do we treat it? And we're going to actually announce some new medicine that's out there that helps, I think, people that are a little bit far along in this concern.
Absolutely. Now, typically the first thing that happens is you try to stratify the men according to their risk. And the 5 variables that we routinely look at, number 1 is the PSA. And somebody with a PSA of 1,000 is very different than somebody with a PSA of 2. We look at what's called the Gleason score, which is determined by the pathologist, and that's a 2 to 10 scale, with 10 being bad and 2 being as good as it gets. Actually, 6 is the most common we see today, which is not a bad cancer. And then we look at the stage, and of course the stage is to what extent spread has occurred. The disease typically spreads into the lymph nodes and bone, and there may or may not need to be an assessment of lymph nodes and bone depending on exactly what the PSA and Gleason score are. But then you also, of course, need to look at the age and comorbidities of the patient. Now, the age of the patient, your 99-year-old patient is different than your 49-year-old patient. And the comorbidities means basically what other illnesses are present. For instance, if somebody in dialysis, severe diabetes, heart disease, that's very different than a healthy patient. So putting together those 5 variables, PSA, Gleason score, clinical age, the age and comorbidities, we're generally able to come up with a pretty reasonable treatment plan.
Okay, and so what are some treatment plans that are being used?
Well, for early stage patients, meaning that it's still confined to the prostate, depending on the Gleason score, is a low PSA and Gleason score of 6 or lower, simple observation may be appropriate. If you have a higher Gleason score, higher PSA, or more biopsies that are positive, particularly in a younger patient, then surgery, radiation therapy, and seed therapy are typically discussed with the patients. The surgery is so-called radical prostatectomy. The seeds are where the radioactive seeds are implanted in the prostate. External beam radiation, which is like X-rays, are used to treat. And these can all be used to treat localized cancer with pretty high degrees of success in general.
Okay. So now somebody has it, but they're a little bit more on a more serious situation, and I thought that's what we're going to talk about.
Again, in this sort of risk stratification scheme depends on how advanced it is. So if it's locally advanced, then we typically use a combination of hormonal therapy in combination with external beam radiation, and that's reasonably effective. Or if it is spread considerably beyond the prostate, into the bones or whatever, then we typically use hormonal therapy. So the first stages of treatment are dependent on the stage of the disease and other risk factors, and then you need to try to find out if it works or not. Of course, some people come on with the disease that is too advanced for local treatments, and unfortunately and inevitably, some patients will fail local treatments. About 30% of patients progress despite surgery. So even if you're operated on, it doesn't mean it's necessarily cured, and that's something often hard for people to understand.
Okay. And so, and in the like later stages, I believe there's some new medication that's out there that's been approved by the FDA. What is that?
Sure. That's Jevtana or cabazitaxel. What I might want to do is to help kind of introduce people to how cabazitaxel or Jevtana might be used. And if a person fails or progresses despite surgery or radiation, then many people will end up on hormonal therapies. But hormonal therapies, unfortunately, do not cure patients, and inevitably there will be disease progression. Of course, that can be years later. I don't want to be, discouraging to all those men on hormonal therapy today, because at one point, 1 out of 33 men in America were receiving hormonal therapy. It's a little less today, but it's a huge percentage of men. But hormones will not work over decades, and when progression, despite the hormonal therapy occurs, we call it hormone-refractory disease. And this is prone to more rapid spread, particularly into the bones and the lymph nodes. And under those circumstances, we have to introduce additional therapy. So now we're often talking about patients who may have failed surgery, may have failed radiation, certainly have failed hormones. And now the question arises as what to do. And today, in terms of therapeutic options, most patients in America with that disease state will go on to receive some form of chemotherapy. And the frontline chemotherapy, first-line chemotherapy, is an agent called docetaxel or Taxotere, and that has been shown to be effective and is FDA approved, but unfortunately and inevitably it doesn't work forever. So when we look at the patients who failed chemotherapy, failed hormonal therapy, failed to radiation and other agents, we're talking about a very sick group of patients. And it's that group of patients that Jevtana or cabazitaxel is FDA approved for.
Okay. So then that's good news.
It is good news because, previously people who have progressed despite appropriate chemotherapy with docetaxel have really had very limited therapeutic options. So you're really looking in the past for people in this disease setting to go on either experimental therapies or, maybe receive some sort of palliative therapy, radiation to the bones or whatever, morphine. And now there's a new therapeutic option that actually has resulted in a prolonged survival for these very difficult to treat patients.
Mm-hmm. Okay. Doctor, thank you very much for sharing the good news with us. And a lesson here on the prostate, very large concern for men. And is there a website that people can look a little more into this?
Gosh, there are a couple of websites that are good when it comes to prostate cancer. One that I might recommend is the Prostate Cancer Foundation website, or PCF website, and that is an organization that promotes research in prostate cancer, and I found them to be very accurate and very balanced.
Okay. All right, perfect. Doctor, thank you very much for taking some time out of your busy schedule, and let's hope this helps some guys. Appreciate it.
Thank you very much. Appreciate the call.
Thank you. All righty. Bye-bye.